My project is completely different from Elizabeth's project. We're like down at the micro scale here. It's probably more in your classic, okay, I'm putting everything together in a book, and so I said, okay, I'll give an overview. And I think the thing that distinguishes my project from a lot of other projects is I took two streams of research that I've been passionate about for all of my life, migration and community health workers, and I said, okay, let's put them together. So this is what I did to put them together, and I'm just gonna sort of go through some of the highlights tonight about what was in that project that really made it exciting for me. So some people say, well, what is it about immigrants and immigrant health? Well, there are 214 million immigrants. And if we added them all up, it would be the 5th largest country in the world. So the immigrants become within our society, and we're not so aware of them, but they're very aware of some of the issues that they face. And that's what this book is about. 5% of the global population are immigrants, and in the developed world, it's 10%. So look around you. I bet you there's some immigrants sitting here. It's very global, and much of it is interregional, which affects what happens. In the US, we win the prize here for the most immigrants, as you can see from this slide. And New York City is a city of immigrants. Over 40% are foreign-born. The other thing that is very interesting about New York City is that we also have many community health workers. There's an estimated 3,000 here in New York. And we have one of the largest independent community health worker workforce organizations in the whole country. And Mr. Sergio Matos, who I've worked with for many years, actually has agreed to join me in this project and working on some of the core chapters. So there's a lot of reasons we went ahead with working here in New York City. So it's hard to visualize when you talk about bridging the gap. What are we bridging? Well, the immigrants are over there on the left, and the health system's over here on the right. And there's this big chasm in between. And that's what the community health workers have to get the immigrants to go across that bridge so they can get the health care they need. Well, why should that matter? Immigrants often are healthier. They come, they're younger, demographics are in favor of them, but they aren't necessarily healthier. And where things fall down is they're worse for a lot of the key prevention and management activities, which feed into some of these chronic disease issues, which are staring us all in the face. So how have immigrants experienced this? In the book, I've consolidated a lot of what they do into some of the themes that people talk about in statistics, but that through the interviews, we've been able to tease out fears connected to immigration status. It's many do not know their rights they have in this country as human beings and as workers. I have heard that some are afraid to go to the hospital because they fear the police might take them because they're undocumented. That was a theme we heard very often. No insurance, so you just wait and you wait and you wait until you can wait no longer. Inability to cross linguistic and cultural barriers. Well, people often say, okay, well, we need translators. But this story I heard from a Colombian immigrant really touched me. She says that she had a translator. She had these meetings with doctors. She was a high-risk pregnancy. But she said that it was very mechanical and formal. One day I was much stressed and did not pay attention to the final part of the translation. The translator was disappointed and scolded me about it. I felt really bad. I just wanted to get out of that room. I felt like I was in front of a machine. I was not able to understand anything or to ask questions. I was not able to know how I was, how my baby was. I felt impotent and insecure. And she was not alone in saying it's not just the language. No understanding chronic diseases and how and what to do. So another woman who came into our program through the work we do in the Head Start programs, she was from Mexico, and her child had been sick a lot with flu and coughs and colds in Mexico, and the doctor kept saying, okay, take this medicine, take this medicine. And she happened to come to one of the workshops that we hosted on asthma, sort of an introduction, and it was like light bulbs went off over her head. Oh my goodness, maybe my child has asthma. So of course we helped her get hooked up to a physician so she could be properly diagnosed, and yes, it was asthma. So she said, I would never have known about this. You changed my life, because now I understand that this was asthma, not flu. And then, of course, there's the anxiety and stress of trying to make it against all odds. I found that this woman, she's actually a Moroccan immigrant. She said many immigrants came here because of war, political instability, and poor security in their countries. Others are economic immigrants who come to this country looking for a better future for their families and children. But they do not find that better future here. They have to work long and exhausting days. The good health they had come with is gone, and they cannot access health care. So even though migration researchers will say they're positively selected, they're young, they're healthy, while they're here, they don't get to keep that health. And these are all issues that the immigrants have to confront. So the immigrants actually don't cross that bridge. It's like a chasm that doesn't get crossed. So where do community health workers fit in? Well, I wanted you to see this, not because I want you to understand all the things inside the box, but that community health workers work in a context, and that context is community. And that's the brilliance of community health workers, is how they connect to the community and help the immigrants not only connect with their own immigrant community, because they're often isolated from it, but with the larger community, so they don't feel so alone, and so they're able to access resources and get what they need. And so the community health worker, if you just had somebody who got trained as a community health worker and said, okay, I can work anywhere, they would be a health worker, but they would not be a community health worker. And so the community part is extremely important. And as we deal with legislation for regulation of community health workers, this is a very important thing to remember, is the context of the work. So with community health workers, you can get all those things. But if you don't have the community health workers connecting with all those things, you're not going to get them. So actually, I gave a talk on community health workers yesterday, and the presenter before me said, well, there's no evidence that community health workers make a difference. And I said, well, actually, that's just the opposite. There may be lack of evidence if you're talking about volunteers. But for community health workers who are in the workforce, who get paid for what they do, recognized for the value of their work in terms of helping people stay healthy, there's a lot of evidence. And this is just sort of summarizes some of the things that we know from the literature, global literature, but also here in the US, about what community health workers do to help immigrants. That's a lot of words, so let's try to boil it down. One of the things that community health workers do, I think that is really important, is they take those immigrant concerns, those things that prevented them from crossing the bridge, and they say, okay, you can't do it because of this. Let's work on it. So isolated from their health care. Okay, so you go out into the community and you're friendly and you're an immigrant and you're accepted. You can talk to people. Unfamiliar with chronic disease risk. Well, then you help with the appropriate language and materials. Help people understand. Can't talk to the doctor. Well, instead of just saying, hoping the doctor will have a translator who might or might not really understand what's going on, you go with the person to the doctor and you really help them communicate more than just translation, looking it up in the dictionary, and so on. So for each of those immigrant concerns that prevents them from crossing the bridge, the community health worker is able to do those things to help them cross. So lo and behold, through outreach, counseling, coaching, demonstrating, supporting, navigating, referring, guess who gets to go across the bridge? The immigrants. So now, a lot of what we're doing in the guts of the book, talks about a lot of those things. But what I wanted to share with you was sort of the feedback from the community health workers, because they're in a sense, they're the facilitators. They're the ones who are making it possible. And some of the things they said about their work, listen, we were in tears, both the community health workers and me, and the people who were helping with the interviews. It was astounding. Here's what one woman said: if life is difficult when you're healthy, can you imagine how it is if you're a sick person? Here they are, vulnerable. The health system is very complex. That's why I work as a liaison between immigrants and organizations that can help them, including medical providers. I also help medical professionals to understand the immigrants they serve. This was a theme that came off very often. It's not just helping the immigrants receive something from the healthcare system. It's also about the healthcare system listening and hearing something from the immigrants about how it is that they could serve their needs better understanding what some of those needs were. And some of the interviews that we did with whole teams of medical providers, for instance, here at Bronx, Lebanon, they said, I can't do this without my community health worker. You know, they show up for team conference, and it was almost like, okay, well, we don't really understand what's going on, so let's wait for the community health workers. So it influences the healthcare system in a mutual direction. Getting insurance is something that a lot of people have talked about, but as those of us who live here in the States understand full well, immigrants are shut out of a lot of the healthcare benefits that are offered through the state and the federal systems in terms of assistance. Most of them have jobs that are often not covered by insurance, so what do? Creative health workers, community health workers, help them get connected to community resources that in fact are there to help them. Translating recommendations, oh boy, this is a biggie, but the example that this woman gave, that was something else. She said, for example, guides, she was working in a nutrition program. Some guides talk about measuring food in cups, but African people use their hands to measure food, not cups. So if you do not adapt everything to the language that they can understand and the process that they know, they aren't going to use it. So I teach them how to measure food, among many other things. And it's success for us to improve nutrition practices for those immigrants. A big thing in community health work is providing support. And it is both the one-on-one support from community health worker to the immigrant, but also in groups to build that solidarity. And again, even in my own research, when I look at it, the sort of the operant factor isn't just that individual one-on-one stuff, but also pooling in the group support. We've seen it with HIV adherence, we've seen it with asthma, we've seen it with diabetes, that once other people can hear that they got it under control. One woman told about how she stopped eating 2 bananas a day, and now she only had to eat 1 banana a day, and her goal was to eat no bananas a day. Bananas was the thing she loved and was causing her to gain weight. She got such support from the group. She overcame that feeling that I'm fat, nobody wants to talk to me. And you know what? She changed, she lost weight, she stopped eating bananas. But it was the group support that made a big difference. Now, the other thing that I think is important about the community health workers is that they don't just work on health. And a lot of people think, okay, these are like little vertical programs. We have an asthma worker, we have a diabetes worker, we have HIV adherence, and that's all they do. Well, that's not the way community health workers work. Community health workers work with the whole person. So if that person is hungry, they're going to help them get food. If that person's landlord is evicting them, they're going to take them to the agency that has legal assistance to help them deal with the landlord. If that house has windows and heaters, but they don't know how to use them, and their child is continuing to have asthma, they're going to teach them how to use the heaters. And so it's addressing all of those other needs that really makes the difference between a health worker and a community health worker. So here are some of the Dominican community health workers with their children. And something that I think when we think about from New York to the global immigrant diaspora, we have to think about all of these lessons, and I think mutual respect and trust is a really important part of it. Another thing I want to point your attention to is the balanced integration to the health workforce. Because if community health workers aren't respected by the healthcare providers, they're not nearly as effective. So we really have to make sure that no matter how we do this, we build that in. The other thing is being proud. And I think that everybody needs to celebrate their accomplishments. And within the immigrant community, within the community health workers, immigrants for immigrants, we have to be proud of our accomplishments. Thank you.
I'm wondering about this, the relationship between the community health worker and the social worker. So are there social workers in this context as well, and what their relationship is? Because I think if we were not immigrants, that would be our liaison, right? Would be a social worker.
Well, not necessarily. In fact, when we were working here in New York on the sort of developing the scope of practice, we had social workers who were participating in the discussions, and they kept saying, well, we do that as social workers, but what usually happens with the social workers is they get channeled into specific tasks, like, okay, here's a discharge, I have to deal with a discharge. Okay, I have a case management plan, and it's a lot about the paperwork, and they're not really in the community. So the social worker is like the nurse. They could be living anywhere and working anywhere, but the community health worker actually knows which community organizations have the programs. So the community health worker is, in a sense, like a social worker, but without the paperwork and with much better community.
Thank you very much for your presentation. I'd like to ask if issues of mental health pose special difficulties in the context of your work.
A very good question. Actually, several of the community health workers that we interviewed work specifically within the domain of mental health. Because very often, you saw the slide about anxiety and stress and depression. It's not just anxiety, stress, and depression. People also can have a lot of serious mental illness. And there's a program that we work with in Washington Heights where we specifically are working with people who are very seriously depressed and have diabetes. And we realize we're never going to make any headway on the diabetes if we can't deal with the depression. And so increasingly, the community health worker workforce is being given the tools to help work with people who have variations of mental health disorders. There's a program we're working with that actually has much more serious mental illness. But again, the same principles hold, that often the community health worker is better able to talk with and help people see something inside themselves that if you go to a doctor's office and you have to sit there, you don't see it. But where you're sitting in your own home, in your own kitchen, you can see things and experience things in a different way. So yes, we build it in. It's not every program, and it has to be done with care because that relationship of trust between the community health worker and the client is very important, and you don't want to rock that boat needlessly.
Sally, I have a question that's about the fact that you're on the faculty at Columbia School of Public Health and it's located in an immigrant community. To what extent has that community shaped this work as you've developed it? And how much of this work is specifically about Washington Heights and based in Washington Heights versus applicable to other cities or other immigrant populations?
The work that I do in Washington Heights is very much influenced by that context. When I came back, I'd been living and working in Africa. I'd been working with immigrants there and migrants, and I was feeling like, well, where's my community? I was feeling like, where's my African community? And so I looked around me, and this became my community. Washington Heights became my community. I had to take my high school Spanish and Flora will attest to it. Sometimes in coalition meetings, everyone would say, Sally, en español, por favor. And I go, and I, trot out my Spanish. So it became my community. So when people talk about working in the community, I feel that has very much influenced how I view this whole process. And in terms of applicability, that's the great thing about being on the faculty and being plugged into the international and the national networks of community health work and community health research, because it's very clear that what we're doing is still very much kind of on the cutting edge. There are groups that are working on the border in Texas, and their work is very important, but still when you think about it, one of the things I see as a common thread this evening in what we're talking about, we're all talking about urban, we're talking about cities, we're talking about people working in cities. There are programs for immigrants in rural areas, but the majority of the influence that I think has shaped my views, and that I think where there is more potential applicability, is in the urban area, because that's where most of the immigrants do end up. I took a slide out, but you can see that most everywhere the immigrants are going to the port cities, to the major points of entry.